Welcome, everybody, Preparedness Partners webinar. I want to introduce Dr. Jim Wilson today. He's CEO and founder of Prosecco Consulting, board certified pediatrician, specializing in operational health security and intelligence. He focuses on anticipating, detecting, and warning infectious disease crises. If it's been something nasty in the air in the last 30 years, Jim's aware of it, had a hand in it, or helped lead parts of it. So, that includes avian influenza, H5N1. This is spread from Asia to Europe to Africa in the mid-2000s. Detection of vaccine-drifted H3N2 influenza in 2007 and 2014. Warning the 2009 H1N1 pandemic. Discovery of the UN as the source of the 2010 cholera disaster in Haiti. And, early warning December 2019 of COVID, which we're all very familiar with. Not to mention, investigating an alleged confirmed laboratory accidents of bioweapons. And I know we have some bioweapon folks in here today. What we want to do today, Jim's going to maybe give like a 30-minute or so overview, some of the stuff that, he's done, specializes in, Prosecco has a hand in, and then want to open it up to some questions. So if you have questions, you came with questions, go ahead and put them in the chat. If you have questions as we go through, go ahead and throw them there. I got some of my own that I'll layer in too when we're done there, but want to first kind of give the floor to Jim to kind of go over some of the points that he really wants to hit. So thank you for coming, Jim. Thank you for sharing this. I know it's busy time in this evolving landscape, but appreciate you getting us smarter, because I think this whole audience here, somebody has a different hand at different parts of it, and it's one that is hard to get clarity on, I think, from a lot of folks, and you can provide some of that clarity. So thank you. Thank you.
Absolutely. Thanks, Drew, for the invitation. Welcome, everyone. I see an awful lot of familiar names on this list, and I just want to give a shout out to all y'all. And thanks for joining us. And it's really fun to see you guys. And Steve and I were just talking, and like, holy cow, this brings back some pretty cool memories. So thanks for everybody for joining. I hope what I share today is helpful, maybe gives us a little bit of hope for the future, right? Because there's a lot of still uncertainty and fear related to health security and how we manage these difficult to anticipate risks. I think if I were to offer this, please understand that everything I'm about to share with you is just our perspective, okay? Our team's perspective. We do not speak on behalf of the U.S. government. We do not speak on behalf of any formal entity other than ourselves. And so you may come away from this saying, hey, these guys are full of it, and that's okay, right? I think that it's healthy to listen to many different perspectives on how to manage a very difficult thing to manage, okay? So with that said, I think what I'll do, Drew, I think my slides are still shared, right? Okay, let's get going then. So I've been doing this work for 30 years. I probably started leaning in this space with the 1995 Kikwit Ebola outbreak in the DRC, then known as Zaire. My interest there was to explore ways of providing us with early warning and avoiding the element of surprise for these frightening risk events, right? So Ebola back in the 90s, back then, we were actually worried that this was a 100% case fatality rate kind of situation, right? And when I was in the rainforest there looking for evidence of viral activity among animal species we didn't even have species names for yet in the scientific community in the Thai National Park, what we realized was, my gosh, we have no idea what the ecosystem is of this virus, much less these seemingly random surprise events popping out of the rainforest and killing a whole village and then scaring the heck out of everybody all over the world. And then they just disappear seemingly on their own. And then of course, Hollywood had preceded our sensitivity to these issues for decades before that with the Andromeda strain and, just reports of strange things happening in the African rainforest and people going in spacesuits. I mean, there's a whole thread to that I would encourage the audience to kind of go back and take a look at. And at this time, me coming up through as a medical student, you had Richard Preston writing The Hot Zone and the Cobra event, and just there was a lot of sensitivity to these issues, bioterrorism and just emerging pathogens of high lethality, right? So back then, we were interested in exploring this question of why were we seeing clustering, apparent, I should emphasize this, apparent clustering of Ebola in the rainforest, where we would see a couple outbreaks appear within a seemingly tight time frame, separated by vast distances, involving different countries sometimes, and then it would just disappear again for another decade or so, maybe longer. And back then, we were trying to leverage assets from NASA, the NDVI, the Normalized Difference Vegetation Index, which is a measurement of how green the Earth looks. And we were trying to figure out, hey, can we measure some kind of environmental anomaly that might be associated with these outbreaks, preceding these outbreaks, maybe, right? So that if we see these signals in the satellite imagery, would that tip us off that we have imminent risk to see Ebola? Now, the next question you would say to yourself is, well, what the heck would you do with that early warning, right? Well, maybe it's just simply talking to these communities and saying, hey, let's avoid bushmeat, right? Don't go in the forest and try to catch diseased primates, for example, right? So there was a lot of intrigue around this, and that was during the time when Rita Colwell and NSF had done some really cool stuff, looking at satellite imagery predicting cholera, right? And Ken Linthicum, and the DoD was looking at using imagery to anticipate Rift Valley fever, right? And so this was kind of in a swirl of interest in leveraging imagery to give us early warning. Now, inevitably, when you do that kind of process, you come into contact with other elements of the government that are rather interesting agencies and people, not the least of which is meteorological folks, right? And so we had a lot of contact with NOAA as well, and they started talking to us about how they approach warning. And so this is really where the beginning of all this conversation around disease forecasting, I think, kind of began, was in this sort of time period, which was really led by Rita and Ken and folks like them, sort of looking at, how do we start to anticipate risk so that we don't feel like we're constantly reacting to these surprise events. So what I'm showing you on this slide here, and this is published a number of years ago, and we'll see if the hypothesis holds up to peer review and ongoing study. But what we're looking at here with each of these boxes, these were outbreak sites in the mid 90s and early 2000s. And what we're looking at here on the x-axis here is a time frame, right? So these are
Hey,
months.
Jim, sorry to interrupt you here, but the slides are not moving for us. Did you click on the next
Could
slide?
be colored boxes.
No, don't say that one. It's still on the title slide on your end.
Yeah, this may be an issue with me using.
Gotcha.
How about
A little bit of lag.
yeah? So are you able to see my? How about now? Can you see it now?
Yep, I see the boxes and the variants of colors.
Great, thank you. So
Yeah.
red is basically an indication of environmental stress, right? Where the rainforest canopy was stressed out. And what we're looking at here is our hypothetical, I want to emphasize that, hypothetical trigger event is what we called this, was basically a drought, right? And we felt like at the time that perhaps environmental stress in the rainforest happening in a sort of a near real-time manner might be associated with the emergence of Ebola. And what's interesting is carrying this forward, there's some recent studies showing that well, perhaps environmental stress lowers animals' ability to defend themselves immunologically against this virus. So maybe that's how this virus is able to move from its cryptic reservoir. At the time it was cryptic, we now know it's bats, down to humans, right? So this was sort of the start of sort of my interest, if you will, in providing warning, right, and getting some structure around the warning discipline. Okay. So our mission, really, it's always been this, is warning intelligence. Now, what do I mean by intelligence? Well, I don't actually mean it in the way that everybody thinks of, when you look at James Bond or whatever. It's really, we use the word intelligence as actionable information, and we can have the whole debate about the I word, okay? But at the end of the day, what we're looking for is it isn't good enough to give warning, okay? We wanna see that warning influence some degree of a response behavior, and that response behavior could be nothing more than having a conversation with your colleagues, okay? And beginning that discussion about preparedness, all right? So, we could talk for days about that, right? But really, we're not here to be yet another website, copy pasting media articles talking about disease outbreaks. That is absolutely not what we're interested in and was not the reason why we engaged in the first place. Um, we're looking for unusual signals here. So the vast majority of sort of these media reports talking about disease outbreaks all over the world, the vast majority of these reports really don't care about, right? We're looking for very specific signals and patterns of human communication that give us hints that that is something that we need to prioritize, because if it moves through the air traffic grid and surprises us here stateside or our allies, right, in their healthcare systems, this is going to be tremendously disruptive, right? So our emphasis has always been really on the infrastructure as a monitoring priority versus the case counts and fatalities that public health tends to focus on. So our work is intended to be complementary to public health, never to supplant public health. Okay. So really, how we do our work is we look at history. So we're looking at historical daily accounts of unusual non-routine outbreaks. These libraries of reports then inform the creation of a signature library, right? So with all of these reports, right, we're looking for indicators. Okay, so when I'm a doc in the clinic, I'm looking for signs and symptoms of disease. And certain patterns of signs and symptoms presented over time give me valuable hints as to what disease I may be dealing with. And then that actually informs my decision to order laboratory tests. There's not much difference when you're monitoring the world. You're looking for patterns here, patterns that might give you valuable hints as to what kind of response you're going to be looking at if you're on the receiving end of this, but also what the diagnosis might be for whatever's going on in that country. Okay. These signature libraries, when you look at enough of these patterns for over the decades, over the centuries even, you start noticing response behavior patterns, right? You start understanding, okay, if this goes, this is how fast it's going to happen, right? And you start anticipating these patterns, right? You start looking for, okay, if I see this indication, I'm going to be looking for this other indication now, right? So it's a series of if then statements, okay? It is our belief that these signature libraries, therefore, support more effective warning and thus more effective response on the back end. So, a lot of analogies, right, to meteorology. Well, that's been the case for a long time now. This is not a new thing, even though it often is presented as such. This is the tornado Fujita scale, right? The enhanced Fujita scale. So Dr. Fujita is a hero of ours, right? 'Cause he in the Beaufort wind scale and the hurricane categorization systems, these gave us a framework to communicate against data or indication patterns that we are seeing, right? And this is what inspired some of our early work, looking at how do we tell people this is a big deal, this outbreak's a big deal, beyond the typical public health language, right? And over we know it.
Interrupt you one more time. The slide isn't seem to be moving forward, so if it's better for you just to keep going, because it is easy to follow you verbally too. I just wanted you to be aware that's still on the color box slide. Oh, there we go.
Oh dear. How about that?
Yep,
Oh,
indicators report warning.
yeah, maybe if I can just get this right there, and we'll just keep trucking with that.
Okay.
Yeah, really, we're looking at how this is, and these are heuristic models, right? There's nothing, necessarily terribly scientific about categorizing increased impact levels, right? But there's a lot of different systems in the national disaster community that have sort of given us inspiration, right? Now, again, warning supporting emergency response. Well, generally speaking, the public understands what to do with some of these warning communications, like with tornadoes. Especially if they live with tornadoes as a routine risk, right? So the difference between a tornado watch and a warning, right? This escalation, right? But notice, and it seems simplistic here on this one slide, but there are actions that are understood that should be taken, right? And this is kind of what we're picking at here is if we're noticing a shift, an indicator pattern of an outbreak that has not been completely characterized yet, we're starting to think about, okay, well, what do we do with that information, right? Well, what would I tell a hospital in New Jersey that's connected to this foreign site by air traffic, right? I mean, realistically, right? Without overreacting. That's the other side of it, right? So in the clinic, let's give you an analogy here, right? I see babies all the time, right? I'm a pediatrician. And man, if you want to talk some stress here, if I have anxious parents bringing in a pretty crabby sick baby, these parents are stressed out, right? And they're worrying about all kinds of things, and likely they've gotten onto Google, and Google took them right to apocalypse, right? Their kid probably has a cancer, based on the search they did online, right? And somehow I got to de-escalate that. I got to say, look, your kiddo has a clear runny nose, right? As evidence in this picture. Yeah, they're coughing a little bit. They might have RSV, right? Respiratory syncytial virus, right? Which we see in pediatrics all the day long in the winter months, right? But it can be a virus that can cause mischief and get that kiddo into trouble enough where we might have to put them in the hospital and keep on them, okay? So there are certain things I'm looking for in this exam. Like I'll see a kiddo like this, 20 kids like this in a day, right? But that doesn't mean they've got something like that, right? In contrast, if I see a child walk into my clinic with purpuric lesions like this, where it looks like they've got bruises all over their skin, immediately my brain is thinking, oh my gosh, I might have to get this kid into an ambulance and send them down to the emergency room and go ahead and call the emergency room. And we might be looking at meningococcal meningitis. We might be looking at meningitis or some other serious disease, but this is not a good thing to see. Okay. And so, in other words, we can look at the overall pattern of impact, but then there are certain early indicators that portend that you're going to need to move right the heck now. And if you wait for the maximum impact to that patient, you're going to be in deep trouble. You're going to be past the point of no return and you're not going to be able to intervene. Okay. So, in other words, what we're looking for are critical indicators. And these are indications of unfamiliar pathogens or high threat agents that cause clinically significant disease. So if it just causes a runny nose, your human caregivers on the ground there, they're not going to notice this, right? So unfortunately, it has to leave a little bit of a footprint there, right? And we're looking for evidence of virgin soil transmission. What we mean by that is the other side of this conversation is whether or not there's enough population immunity to buffer the impact on the infrastructure. So really what we're looking for are crises that could move very quickly, become very complex, and imply very messy response. So I mentioned before that we've looked through history. Well, indeed we have. And actually, our library goes back to the 1600s now. This is kind of an old slide, but we've looked at the influence of pandemics of note. Where if we still think that 1889 was influenza versus coronavirus, 1918, of course, 57, 68, 1977 with the reintroduction of H1N1 to the planet. HPAI, H5N1, we were involved with 2009, saw multiple rounds of MERS, Ebola, Marburg, So when we look at all these kinds of events, there's a lot of interesting patterns, right? Now, for our BW folks out there in the audience, let's talk about, alleged BW incidents. Okay, let's emphasize alleged. This is the warning signature for Mashonaland province in the former Rhodesia, now known as Zimbabwe. And this was the world's largest epidemic of anthrax, right, involving over 10,000 people. And we took a look at this really from the perspective of less so can we prove that this was an act of biologic warfare, and more so, hey, people were worried about this event, the questions were raised. At the end of the day, we don't really care. What we're really interested in is what is the warning signature? What was the impact to this community over time? What you're looking at here is the output of one of our systems we use to assess these events. And so that's that model assessment on the y-axis. But across the x-axis there, this is the timeline as the days go by, and we're watching the pattern of human communication around this event shifting from, okay, they recognize they've got an outbreak of anthrax, but not a big deal, most of it cutaneous. But as they started seeing all the known clinical forms of anthrax showing up in their hospital, now you got a public health emergency sitting there. You have hospital strain and enough anthrax presenting in that hospital where it became the leading cause of admission for all patients, to the point where they thought their staff were at risk for transmission of anthrax in their facility. Holy cow, never really see that routinely, right? To collapse of their infrastructure where they were having a very hard time getting control of the situation. Here's another example, transitioning from basically a public health emergency crisis to hospital strain, to immediately losing control of the hospital, and then the government officials decide to pack their bags and just leave the city because, well, they're done. And this was the Philadelphia yellow fever epidemic in 1793. And so, what's fascinating to us is, even though we're going back to a time period where they didn't have the same medical infrastructure and knowledge that we have today, the behavioral patterns are remarkably similar, right? And it informs our understanding and our ability to recognize, hey, that's an unusual looking, non routine pattern of communication around this event. And again, what we're looking for is a way to detect and recognize these signal patterns ahead of laboratory confirmation, ahead of forensic epidemiological investigation, so that we are cueing in and starting to look more closely at a situation. So again, understanding signatures enables us to anticipate the next signatures to watch out for and to compare these routine known signatures to what might be non-routine, right? We're also monitoring the impact to these communities, and we're trying to cross-reference, okay, is this a community comparable to the communities in the United States? Now, that's a devil unto itself for any of you on the call that have tried to do this kind of work of trying to compare our medical infrastructure to other countries' medical infrastructures. That is easier said than done, and man, we could have a whole week-long podcast over that one. But the idea here is understanding, okay, if this situation impacted these hospitals in this way, we may need to anticipate that for our hospitals here stateside, and that's valuable information to share with them. Coming back to critical indicators, this is an evolution cycle, an indicator cascade, in other words. So going from left to right, so this is the time frame, and each of these little colored boxes, the colorization relates to different categories of indicators that are lighting up slowly but surely over time. And what we notice is that as time progresses on the ground with an outbreak, right, that we're monitoring, you see an increase in the diversity and complexity of these indicators over time. Exactly the same as a patient experiencing illness, where they start with a runny nose, then the next day they've got runny nose, fever, and a little bit of a cough. Then the next day, runny nose, little fever, cough, increased heart rate. Now they got a rash, and things become more and more complicated. But in the middle of that, we might have on day 2 or 3 the initial note of a critical indicator that actually will escalate this particular outbreak out of 5,000 other outbreaks we're looking at throughout the world to the top tier of interest and concern. So, critical indicators, they enable prioritization of signal monitoring. they do empower anticipation of what are we going to look for next. So historically, we've monitored the world across 50 languages. We used to have human beings doing this work. Our analysts, no matter what operation center we've worked out of, and I've led many different op units over time. What we've noticed is that our analysts tend to get burned out, and this is actually a fairly common thing, for any risk, monitoring group. They just get burned out. No matter how interesting the topic is, the eyes glaze over and their brain just kind of goes numb. And this is where, we do think that AI could assist, in helping curate and present information to the human, but you're still going to need the human to look at it. We do use contextual information, satellite imagery and in our own signature libraries. And occasionally we will engage with human sources. So we do manage human networks, and sometimes we will make suggestions to people, like journalists, and say, hey, uh, uh, you're reporting on this event. We find this event to be interesting as well. You may need to look for this, this, and this, because these are the next indicators we're watching for. And if you hear about it in your network, this means we're all going to be in trouble, right? And we've done that a number of times to help draw out and validate different hypotheses about what may or may not be going on. So here's an example with COVID. So certainly we picked up on the reporting in late December 2019 of unusually atypical severe respiratory disease. We did make note that we were, aware of the situation on New Year's Eve. We also made public note that we are quite connected to Wuhan by direct nonstop air traffic. We did drop a hint to WHO that we were on deck and watching this on New Year's Day. So if you notice the time frame here, these are holidays, and people aren't really very engaged in the office during this time of year, which is, bore some similarity to what we saw with SARS back in 2002. But we did say that we had assessed that it was not SARS 2002. This was something different, right? And then on January 5th, we had indication it was a novel pathogen that we were confident about, and we issued warning to Nevada's hospitals. Now, why Nevada's hospitals? Well, at that point, we were leveraging our collaboration with the Nevada Hospital Association to test out a hypothesis, right? Our experience working swine flu in 2009 showed us that if we only issue warning to federal or international organizations like WHO, well, then we have to sit back and keep our mouth shut and wait for them to engage. And after going through that experience now, actually several times, we've decided that actually the world is a different place. It's more complex, and the element of a surprise is still in sort of the network. And we are now advocating that we need to teach hospitals how to do some of this for themselves. So, in other words, teach them the basics of how to interpret warning signals, and then apply that to measures they can take themselves while we're waiting for peer-reviewed guidance or the gold standard guidance that we might expect from WHO or CDC. Because when you're dealing with these types of rapidly moving risk events, we don't, for some of these poor hospitals who come into early contact with the situation, we don't have time to wait. We need to, start to prepare now and protect the staff of these facilities, right? That was the Toronto lesson, right? With SARS in 2003. So here's the critical indicator sequence for COVID in late 2019, early 2020. So the critical indicators, like the overall indicator patterns, you'll see them start off like onesie twosies, and then they just build and build and build and build. And so when you compare that initial slide to this slide, you'll see that we did not wait until the maximum impact in Wuhan to start to raise the alarm and encourage hospitals to roll up and prepare and engage. Right, that happened very early at an event that was really at a level 2, or you're looking at a public health emergency in that country. So here is a sort of a summary slide of that, sort of pointing out that, again, we do find understanding the full impact pattern to be incredibly helpful, but that's not what dictates the op tempo for warning communications, right? We're actually using the critical indicators to do that. Now, let's talk about H5N1. Are we all on the same page as to what the critical indicators are, the warning indicators? We are not. And I say that emphatically. And I say that across our allies, our national leadership, our federal, state, local. We don't have, it's our personal opinions, right? That we're just not on the same page with that dialogue. And if the critical indicators are reported, do we know what to do about it? Well, I think that we probably understand the answer to that question. We know some of the answers, but not all of the answers. Okay. And I do want to emphasize, we don't have all the answers either, right? But we do have a notion after the history, right? So again, these signature libraries that we maintain, we've seen how this goes down, right? So notice we're not paying attention to epidemic curves here. We're looking at what happens to that community. If a hospital can sail through these crises without even skipping a beat operationally, well, okay, you're not going to see us get as interested in that event. But here in the top graph here, you're looking at an influenza pandemic that caught this particular city by surprise. This particular influenza pandemic was considered mild. Okay, so they basically drifted into some transient hospital strain, but not a whole lot of impact and not too many staff members getting seriously ill enough to die, but a couple of them were hospitalized. Okay. In the bottom graph here, going from left to right, this is a time frame here. You're looking at a community that went from a public health emergency to total collapse of their entire healthcare system with threats to their social order literally within about 2 weeks, okay? So for them, this was dramatically impactful. Every human being in that city was rolling up sleeves to try to help defend their community and respond. So different gradations. So this is the other point of this slide is we need to acknowledge that there's different outcomes that we may see from these types of events. And I do think, and anybody who's followed us on LinkedIn knows that we're very critical of just jumping right to 1918 every time we see a health security risk. That is just simply not reality. Reality is it looks more like a hurricane season, right? Where maybe we see Cat 5, right? But let's talk about tropical depressions, right? We see a lot of tropical depressions. So there's a range of potential impacts that we may expect. It's just the difficulty in predicting that. That's what causes much of the stress. Now, this slide, we showed you the top graph. This was that community that experienced an influenza pandemic of maximal severity, and they got immediately overwhelmed with threats to their social order. Then slide below it, or the graph below it, that's actually the implied response actions from an infection prevention standpoint that we're now bridging with the warning signatures. So we are looking at, as the days go by and we're tracking the evolution of a warning signature, we are really getting into the weeds now and looking at what can infection preventionists do for their hospital to begin to prepare their hospital in the event of a surprise introduction of patients associated with this particular risk. And what we're finding is there's actually quite a lot a hospital can do while we are waiting for that formal gold standard sort of guidance that we could expect from public health in these fast moving but rare risk situations. Okay. So kind of what do we do? Well, we provide online decision support. We do have reach back expert support, but I would argue that at this point, in the game, we've done plenty of fishing for people, for our clients. I would dare say that we're now of a mind where we'd like to teach people more to fish for themselves. We think that's a better path forward. Okay. So our vision overall, though, is to promote a standard lexicon for warning indicators and assessments. Okay. We need to get past this business of copy pasting and sharing media articles. We need to get into the weeds a little bit and talk about, well, what indications are we actually seeing? Okay. You'd be able to share these assessments with other analysts. We need to grow this discipline, right? In my mind, I still see this as kind of a Wikipediaized, sort of process, not unlike clinical medicine, where we debate and sometimes we revise our longstanding hypotheses or theories about how disease evolves over time for a given pathogen. Uh, this to me is healthy. This to me is growth of a discipline and growth of our processes for being prepared for these types of risks. And then really, the bottom line is we need to know what the heck we're doing with response, right? And that too is its own debate. One hospital may feel strongly they want to do XYZ response actions, and another hospital may feel quite differently about that, depending on their level of exposure by air traffic or cultural diaspora, or the types of patients that they see. Okay. And that debate is a healthy one as well. Okay. So that's kind of it for my, slide presentation. I kind of wanted to get it wrapped up as fast as I could to get to that 30-minute mark to enable folks to ask questions. But I guess I'll just stop right there and see what you think, Drew.
I had so many questions. That was amazing. Thanks, Jim. That like helped fill in some blanks for me. I wrote some down and I got some in the chat here. One of the things you mentioned that kind of stuck out for me, and you framed it well. You said, essentially, you're working with public health. You're not replacing public health, right? Public health has these classic indicators. Their flu season, whether it's over the counter drugs, ER visit levels, upper respiratory maintenance, and you're looking at things of the comms traffic, the contextual information, the human intel, and other things. Can you give like another example for us of how you're working with public health, not replacing what you're doing, and how public health is doing another mission, but they're tied together?
Well, we tipped off the global alert response network, right? That we were on, that we were looking at this situation, right? So that's our handoff to health, right? That actually signals to them a little bit, right? So the last time I reached out to WHO was cholera in Haiti, right? And that turned into quite a interesting conversation there as to how did that happen, right? And then the time before that was swine flu. So they know. So the principals in the shock at WHO, they know who I am, right?
Mm.
So I just say, "Hey guys, just heads up, this is what we're thinking, but you do you, and they got to do what they got to do within the constraints and strengths that they have, right? Meanwhile, we're going to move forward and we're going to try to help people roll up and get ready to start looking for formal reports from WHO, formal reports from CDC, et cetera. And sometimes we're successful with that, and sometimes we're not, right? So I wouldn't necessarily portray this as a perfect process, but I don't know. One of our colleagues said, "You guys are like midwives. You kind of, you're helping the baby delivery process,
Yeah.
but really, it's not mama having the baby. So
Yeah.
so I don't know. It's just we're more facilitative, I guess, if you will."
Yeah, that makes sense. Another thing that stood out to me, Jim, when you mentioned like the signature libraries and patterns, and you said there might be a role for AI when it comes to that human intel, and someone put in here about GIS and crowdsourcing and how you might leverage that. But what's the complementary role you see in AI in this? Because there it is partly a game of patterns. No.
Yeah, so John Negroponte, early on, he pointed out something, U.S. News and World Report. You can go back and look that up from, I think it was like 2007. Steve might remember this quote, but he said, "Be the first to be right, not necessarily the first to report."
Hmm.
And you'll see talking like that on LinkedIn, right? So the recent
Yeah.
DRC X thread, you know, if The problem, and you'll see it in our actual timeline on COVID, we actually purposefully hesitated a good 24 hours before we said anything about Wuhan because we have been monitoring China a very long time, and there are false alarms, right? It is what it is. There are all the time you'll hear about mystery virus. That's the classic phrase, quote unquote, mystery virus, causing a panic evacuation, right, of some village or whatever, right? And if you jump right to the end zone and say, well, that's 1918 and we're all going to die, you do that enough times and you just blew trusts with your constituents, right? And these are people who might be making billion-dollar decisions to execute response. Okay, so this is the devil of a balance, right? If I ask 5 to 10 professionals how they want to receive warning communication from us and at what part of that particular timeline they want to hear it, I'm going to get completely different answers from everybody, right?
Yeah.
So it is indeed and if you do, damned if you don't kind of situation, but you need to be careful
Yeah.
because there's a lot of ways. And what Negroponte was hinting at was the massive amount of information now available to us thanks to the internet, but also the massive amount of noise. And we see far more noise than real signal in this world, after going through gobs and gobs and gobs and reams of information over the decades. So that's just
Yeah.
our take on it.
Um, I wanted to do a little make believe with you, and you get to pick one lesson from your experience and Prosecco's with COVID that we could make a tangible difference in how we're doing health intel warning and that will affect some outcomes at our healthcare systems or our communities. If you could do one pivot, one shift that we're doing, where would you put that energy?
Wha Can you be a little narrower with that question? I mean, are you talking health intelligence warning systems
No,
or comes
what comes to my mind is when you were describing, I think a lot of what you do and the challenges you face, it sounds is the standardization. When you brought up the other hospital systems, right, in other countries and how they do it and how they admit it and how they collect data and what data they're sharing. It is such a myriad of info. And you went through this and hats off to you and the team of trying to make sense of all this different info and different layers coming in different languages. What is it that we can do? If you could change something that you saw in COVID that is such, whether it's a low hanging fruit, tangible, practical change that you think realistic we could accomplish in this as a team.
Okay, so yeah, thanks, Drew. That's a bit more that yeah. So you saw me getting fussy about this request for a nonpartisan COVID commission, right?
Mm.
And several of you have seen me posting, picking at media reports from everything from the hypothesis of a lab accident to how did we do with response. You see me picking, right? Like we need a nonpartisan COVID commission. It may take years to go through all this, but we need to go through this in a dispassionate way to understand all of the little lessons that we would want our children and our grandchildren to learn, okay? Because let's face it, we may not see something like this again in our lifetimes. It's an opportunity. And from our perspective, we are darn sure that we have multiple perspectives on how this played out that are not known publicly. Yes, we were interviewed by those folks that put together that COVID review book, the former 9/11 Commission folks. And we had hoped that that would have expanded into something bigger, but honestly, they're looking at so many different people and so many different perspectives. Ours was like just a molecule, right? But from our perspective, there were many, many, many things that we really ought to capture. And if I were to give an action item recommendation, is we need a conference. We need a conference where we sit down, we unpack at least the warning intel piece of this. And when I say warning intel, I'm not talking about investigating the question of a lab accident. Quite frankly, from our perspective, we don't actually we cannot get hung up about attribution questions when we're in the middle of a live emergency response. Okay. And that's a tough thing to say. right? Because that evidence has a time decay associated with it. We all know that, okay? From our perspective, if our nation or allies' infrastructures, right, are able to show the world that we're able to handle a hit, even if it comes by surprise, even if there's an attribution question associated with it, that is its own deterrence, strategy, right? Is like we need to be strong, enough with the hyperbole, enough with the fear of the sky falling with every little thing. We need to show a little bit of stiff upper lip and start rising to the occasion here, right? Because we're sending bad signals. Okay.
Yep.
And so when it comes to what do we do? Well, what I'm itching to do is to have a conference where we pull people together who are truly interested in operational preparedness. I'm not talking academics. I'm not talking writing think tank papers here. I'm talking about I want to sit down with a battle hardened nurse who sat through the first wave of COVID, where their hospital took it in the face by surprise, got overwhelmed, saw her colleagues dying down the hall in the ICU. That's the person I want to talk to, right? We want to talk to the warriors, and we want to talk to them and say, hey, listen, does it make sense to teach you our discipline? To show you how to interpret this stuff for yourselves, for your facility. Next, what would you do with that information? Let's find some degree of a consensus around this conversation. I think you will find there is something here. There is something that can be done. The question is, well, who cares? Who would want to show up at a meeting? Who would want to fund it? Now, I would argue that right now, there's quite a bit of uncertainty around those questions.
Yeah, did not think that would be the case, pre-pandemic, but the environment we find ourselves in. I have a few more questions, Jim. I also want to, before I forget to, for the folks here, the hospital associations, the state agencies, the large jurisdictions, what's the best way for them to get a hold of Prosecco and you if they want to continue this company?
Yes, sir. So, let me do this. I'll just type in my email address in the chat box here, which I'm not sure if I can do that actually.
We can't, Steve, pull it up. Steve, do you mind just finding Jim's email and putting it in there?
Yeah, sure, Jess. And I pulled up the invitation, same one.
Yeah, go for it, Steve. You're okay to share that.
You got.
And I'm on LinkedIn as you can reach me through LinkedIn.
Yeah, I recommend doing that too. That's where I get about half my education now, Jim. So thank you. I got a question here from that I think I've gotten like 3 different ones, all on POC testing diagnostics. So it says, do you ultimately think that we need to be building better real-time hospital POC diagnostics for surge alarm trigger, or what might be happening in a patient population? Same question for animal surveillance testing in labs, environmental labs too. Where do you land with that?
Yeah. All right. So let me start with the One Health perspective, right? I was hugely influenced by our veterinary colleagues growing up, and that my first slide with Ebola should show you that, right? That time I spent in Africa was with a French veterinarian, and he taught me quite. And so, yes, having a point of care test ability, right, that is validated, right? That's the key, right? And that would be the worry of CDC, FDA is that the test kit is accurate, right? We don't want to mislead people with these test kits. And we got into that trouble with COVID. So it's a valid concern, right? But to have that available, like in my clinic, in my clinical life, right, as a pediatrician, I can test a child with a molecular test using ID now, right, and tell if that kid's got influenza A or B within 5 minutes. It's amazing. Like when I first started pediatrics, we'd have to send the kid have to be hospitalized before we test them, and they better be really, really, really sick, like going to the ICU kind of sick. And then we send the test. We don't get it back from the ref lab for 7 days. Meanwhile, the kid's been so yes, have care test kits that are species agnostic, ideally. And I know that that's its own devil. Yeah, guys, I was at Plum Island. I mean, I've listen. I've seen this across the species. I'm aware of the challenges, but that would be the pie in the sky, right? Like if we could have anything we'd want, that would be wonderful, wouldn't it? Right? Because then you can test your cat, test your dog. I mean, if it was a home test, hey, that'd be cool, right? Now, who's going to pay for all that? Like, let's face it, we don't have all the money in the world. We think we do, but we don't, right? So I get it, right? As far as the POC debate, okay, you did see me picking a fight there on LinkedIn. I was picking at it, right? And the question is, we know from COVID that the delays in access to testing at scale, right? And that's the key difference here. CDC and our public health colleagues are fantastic if you've got the onesie twosie cases coming in and you're worried about this or that disease. And if they've got the kit ready, they can get your result pretty quick. But if you have a sudden surge event and now all of a sudden you have to test a whole ton of people, you're going to be reacting, right? And if you don't have that test, now you're going to have morbidity, mortality associated with that inability to test these people and identify who's at risk, who's not. We saw that with COVID, right? And there's now been some published papers on this, and that is a lesson, right, for the future. So it's up to us to decide, okay, is this something we want to try using the example of H5N1? Acknowledging, and I want to be really, really clear about this, again, no one can predict if this is really going to go, okay? And if it does go, how severe it'll be. It may not be very severe. It might just be this conjunctivitis presentation. I don't think we really know. And this is coming from someone who monitored Asia, when H5N1 was in Indonesia, right? That was scary. I'm not going to lie. We were worried, right? And nobody could tell if this was going to really go or not. Meanwhile, everybody in Washington is worried about Al-Qaeda hosing us with anthrax. It felt like all the attention was going there, and we're watching Indonesia. It's like, I don't know if we got our priorities right here, folks, but we know that didn't go at that time. So we need to acknowledge that we really don't have a good way of predicting this stuff. The best that I think we can hope to do here is use the opportunity to bring forward some potential lessons so that we're getting into the habit and behavior of being a little more proactive with testing, for instance, right? So that's why I'm provoking the question there.
I got a couple more questions for you. It's a it's a it's a pepper fire round. Um,
Yeah.
someone mentioned the current post-COVID environment of mistrust, some active disinformation, or at least
Yeah.
more channels that it gets out more. Has that had any effect in how Prosecco, how you go about your business and forecasting, and how you communicate? Any ripple effects of post-COVID and the communication lanes?
Oh, yeah. So let's unpack that. I was waiting for that. We could have our own podcast episode on this one. Let's acknowledge, how did I come into this in the first place? I came into this in the first place by reading sensational media articles about Ebola in Kikwit, and reading The Hot Zone, and reading Lori Garrett's. And, I'm conflicted because on the one hand, if you don't have these incredible sensational stories about these incredibly scary risks, right? How do you compel somebody to make this choice to come into something like this for a career? Okay. On the other hand, you go too far down that road of sensationalism and hyperbole, and we utterly blow our foot off when it comes to trust with our public. And boy, has that played out, right? In spades, right? So this is why you see me getting antsy on LinkedIn is like, man, if before I die, if there's one imparted lesson, it's watch your mouth. Like we just, we really don't, this is hard work. Okay. It's kind of like me talking to parents about their sick kiddo. Hey, what I see today is what I see today. This kid is likely to do just fine. But here are the things I want you to watch for. And if you see this, I want you to bring them back and let's reevaluate. Okay. That happens all the day long. It happens all week long, right? And that's my life as a clinician. Same is true on the health security side is we've got to get out of this habit of, well, I want to be famous. So therefore I'm going to hype this to the gills and call it 1918 no matter what. That's just not the way to build trust, right? We need to we got to do better. Now, misinformation. I will answer your question by saying that, yeah, we saw patterns of that with 1918. So we come back to our signature libraries. When you really understand what these signatures look like, you learn to anticipate, okay, this is going to be a thing. You're going to get the rise of the armchair expert. You're going to get the rise of the armchair expert associated with a product they wish to sell and capitalize upon the crisis. You're going to see a rise to misinformation. You're going to see the habit of attributing this unusual event to someone did something, right? These are patterns, right? And these patterns have been reproduced over the ages, sometimes with validity, sometimes not. And these are things you need to be aware of, right? Um, when I'm asked who I worry about the most, it's classically coming from the perspective, oh, is it going to be the Chinese? Is it going to be the Iranians? Is it going to be the Russians? I actually worry far less about state actors than I do about our own folks, right? And being honest with everybody, I've said that repeatedly. Um, we've got a problem in this country of trust and critical thinking and education. And I mean, we'll let others get into all that, but that became a bigger problem than I think any of us anticipated.
Sure. Last question. Since it's front of mind, so so many of our local public health folks trying to communicate avian flu, what are you watching for that? Where's your mind with that? What should we be watching for that?
Yeah. So here's the uh, not to sound political, because we cannot be political. Is not we are not political. Um, but I will say that this is indeed an uncomfortable truth, right? It is after living through reporting and monitoring on an H5N1 for decades now, one thing we've learned is we pay a little less attention to the fear of the sequencers, right? The folks that look at the genomic sequences. We acknowledge their expertise, but there's a difference between seeing a sequence change that looks concerning and a systemic effect, okay? Meaning an abrupt inundation of a hospital, okay? Our habit is to monitor infrastructure. We are looking for signs of a surprise hit to any facility in the world due to an influenza-like illness where it has caught that group by surprise. They are struggling to diagnose what's going on, and there are indications that they do not have control, and they are significantly concerned where they are reaching for help. And that could happen here inside the United States. That may happen in Cambodia. That may happen elsewhere involving a totally different pathogen than the one everyone's talking about right now, right? It might happen with Mpox, okay? The things that we've learned over the years is be prepared for the unexpected, right? No one saw H1N1 going in Mexico, for example. And we had just finished publishing a paper emphasizing how important it was to keep our priority eyes on China because of their ecosystem, right? For the next respiratory pathogen. So I don't know. You learn a sense of, humility, but also a sense of don't react to every single thing you read about. And keep in mind that the Cambodians, they're dealing with their own concerning sequence changes going on with H5N1. And we would suggest that, yes, it's here in this country, H5N1. We have limitations in our ability to surveil its evolving risk. We know that. It isn't going to be perfect. And the uncomfortable truth is we're kind of waiting to see if there's a surge event that emerges in the middle of this before we're able to make a decision finally whether or not we're going to have access to point of care testing. And then we're all going to be reacting in a sequence after that, if it happens here in the US. That's our sense of it.
That's helpful. Thank you. Thank you for that. Thank you for everyone coming. Jim, I got a few direct messages. People asking to come back. Maybe we'll schedule a check-in in 6 months. But one of the messages, yes, I put the webinar link in for the upcoming webinars. We're going to have Liam from British Columbia government talk about the planning they're doing for World Cup, and we'll have Justin there come do a little demo on his AI and what he's been building there with Prepper, which is pretty cool. So I don't know if that won't take an hour, but it'd be pretty neat to see how he does that. We might do a live scenario or something. And then the folks who messaged about Logista, yes, we finished up our beta testing and we're rolling out this spring. So feel free to email me. We can have a conversation with your agency on the disaster logistics system. But that was all the direct messages. Thank you, Jim. This was fun. This made me smarter. It helps put some things in context for me. It's such a evolving and confusing landscape. And, me coming with a background in public health, I can't imagine people don't even have that much exposure to it. So thank you for that. Thank you for everything you and Prosecco do, the important work. We'll stay in touch and link anybody up with questions. We'll link you guys up. Thank you.
Thanks everybody for joining.
Yeah. Yeah. Thank you everyone attending, everything you guys do in your communities as well. Ciao, ciao.
Thanks, Jim. Take care.
Take care, guys.